Yeah, so welcome to Decoding CTO, case 32. I'm Dr. Sharath Reddy, interventional cardiologist, so Director of Medicover Hospitals. So today we brought a good concept which can be used in CTOs with ambiguous codes, that is escalate and embed, knuckle and direct. So this is a case of 67-year-old exertional angina with a normal sinus rhythm and good LVRV function, had chronic total occlusion of right coronary artery, and procedure was attempted and failed before in another center. So yeah, this is a right coronary artery anatomy. You can see there is a long segment CTO and distal RCA, and there is a loop in the right coronary artery, so which can be appreciated here. I think I'll take laser, so we can appreciate loop here. So, and it is very long segment CTO, and also there is bifurcation immediately after distal cap. So this was the failure for the first attempt. You can see what exactly happened. So they started wiring. I think this is a pilot wire, and you can see the wire and distal vessel relation. So it appeared wire is totally in a different course in right coronary artery, but here also this is the distal cap, and wire appeared to be in a different direction. So understandably there is a loop in the proximal RCA that says a strong possibility of another loop in the course of CTO. I think that is the reason, because of the loop, earlier operator couldn't decipher the course of the vessel, and they stopped there. Yeah. So what is important in this failed procedure is, if you look at the wire movement, so wire appeared to be within the vessel architecture. So the movement of wire is along with the right coronary. So wire is dancing along with the right coronary artery. That says it is within the vessel architecture, and the course is in the course of right coronary artery. Most likely there must be some bend here. So because of which we are not able to really align the wire with the distal cap. So with that understanding, yeah, this is a JCTO score for this patient. You can see cap is kind of ambiguous, but there is only a small side branch. So I was guided cap puncture is not possible. So we can just scratch and go, and it's a long lesion, and there is definite angulation because we are anticipating a loop here, and it's a retry lesion. So overall it is JCTO score 4. And coming to the wiring strategy in this patient, so proximal cap is ambiguous, but we don't have a side branch to really do an IVUS guided entry, so we can just go with a scratch and go. And if once wire is confirmed within the vessel architecture after scratch and go, so we can do either antegrade wire escalation or knuckling, followed by, if that is successful, it's okay, otherwise we can go retrograde. So I'll depict complete wiring strategy in subsequent slide. Coming to the challenges, yes, one is ambiguous cap. So already I explained, we can do a scratch and go there, and also ambiguous course of the vessel. This is something which is most important in this patient. So we can use a knuckle wire and to advance or cross CTO segment. Then at the distal end again, we can do wire escalation, which I'll explain. And obviously in such patients, I would have very low threshold to go retrograde, as there is a good interventional collateral for this patient. Yeah, the wiring strategy which I wanted to use in this patient is, take a microcatheter and park it proximal to the proximal cap. This is where we can park microcatheter. So remove your Y, and then escalate wire to pilot 150, because this is a wire which is much safer than Gaia wires when the course is ambiguous. So escalate to 150, and once wire is gone, you confirm wire position in two views, that wire is dancing with your microcatheter, and then you advance microcatheter into the proximal cap, that is embed microcatheter into the CTO segment, and then trap this microcatheter with a balloon on the side within the mid RCA, so to get enough support for your knuckling. So next, bring a knuckle wire. So when course is ambiguous, I don't prefer power knuckles, so I prefer knuckles with Fielder XTR or cyan block. So you take a knuckle and advance this knuckle, and let us cross the loop. So advance knuckle till it crosses the loop, and it becomes in straight line with your distal RCA. So it can go in this direction, or it can go like this if the vessel is straight, and it can go like this if the vessel is showing a loop like this. So this part we are not clear, but however, so our advancement of knuckle is till the point where it is coaxial with your distal vessel, which is visible from retrograde injection. And then you advance microcatheter here and take a directable wire and direct into distal vessel. So essentially it is initial escalation of pilot, and then embed microcatheter here, and then knuckle to cross the loop, but don't spoil your distal the segment before the distal cap. Don't create a space here. And once the knuckle is here, advance your microcatheter here and take a directable wire direct into distal vessel. So it's a escalate, embed, knuckle, and direct. So this is the technique which can be used in this fashion. So this is a dual injection, so you can see, and then we went ahead with the so there is a microcatheter and this is a pilot wire. So the pilot is advanced into the CTO segment, and we are confirming the wire position in the vessel. You can see the wire is dancing along with the right coronary artery, so that says wire is in the vessel architecture. And once it is confirmed, we advanced Corsair into CTO segment. We are embedding Corsair into CTO segment here, and after embedding, inflate the balloon. This is a 3.58 balloon to trap the microcatheter, and then remove the wire from Corsair, and then knuckle. So we used Fielder XTR here. So take Fielder XTR and advance knuckle till it crosses across the loop. So you can see here, so we are advancing knuckle. So in this case, we could advance knuckle up to this segment where the loop was there, but I couldn't really cross the loop, but we understood the location of the loop with the knuckle in this patient. We advanced microcatheter till then, and then we took a pilot again, so just to explore and understand the vessel loop. You can see here, so this is how pilot has gone, and you can see here, so there is a big loop which is visible in elevocranial, and you can also see the entire antegrade gear is dancing with the vessel wall so which says we are within the vessel architecture. So once this wire is beyond, originally we wanted to bring knuckle beyond this loop that is up to this point. Since it is stuck here, we brought a pilot up to here, and now we advance this Corsair beyond this loop. So once the Corsair is beyond the loop, so here literally it is a straight segment, so which can be crossed with a directable wire like Gaia 3. So that is what we did. So now Corsair is advanced beyond this loop, you can see here, and over the pilot, and next we switch to a Gaia 3 wire. So that's a directable wire. So, and we directed wire into the distal vessel. So you can see here the wire is already into the PDA. So, and once wire is into PDA, we used a double lumen catheter to cross into PLVB, and we dilated the lesion, and then we did an IVUS. So you can see in IVUS, this is IVUS from PLVB. So IVUS clearly shows, you can see here, PDA comes at I think 12 o'clock here. Yeah, so this PLVB is fine. You can see this is PDA wire. So, and you can see here, this is a false lumen. So it's, so where we took Gaia and re-enter, you can see this is all false lumen. Sorry, this, your IVUS is in false lumen, and this is all true lumen. So true lumen is sitting at 6 o'clock. So entire area where we actually knuckled is in the false lumen, and the true lumen is sitting here. And we re-entered into the PDA before PDA origin. So this is very important to understand, before going ahead with stunting, because we shouldn't lose any branches distal to the distal cap. So as we understood with IVUS, so you can see still it is in the false lumen, and this is all the compressed true lumen. I think now it comes into the true lumen. Yeah, now you can see all the layers of the vessel are there. So it came back into true lumen. So so it went into false lumen and again re-entered back before PDA origin. Okay, so you can see here, so this is a PLVB and its size, and you can see here this is a false lumen proximal to the PDA, I think almost 10 mm proximal to this is a PDA origin. So this is where we actually entered into true lumen. So this is the false lumen, and you can see this is proximal, I think at B3. So this is where we are in the true lumen again. So all this segment from this B3 up to this is false lumen. You can see some places we can see the true lumen is compressed on one side. So yeah, this is the length of the stunt we need. So we went ahead and stunted with 2 stunts, and this is the final result, with preserved PDA as well as PLVB flow. So which you can see, and you can also appreciate the kind of loops within the vessel, which we crossed while doing, wiring. So this is a first image, and this is the final image, and you can see the loops across which we crossed, and the strategy which we used. So to conclude, Escalate, Embed, Knuckle and Direct would work in ambiguous core scenarios, especially in right coronary artery. Stay away from distal cap when knuckling is used to preserve directability of your next wire. Switch to parallel wire or tip detection ADR if first wire is subintimal at the distal cap. Thank you. So you can subscribe to my YouTube channel to get updates on similar cases, similar complex CTO interventions. Thank you.